Hi everyone, my name is Elise Robinson. I'm 16 years old. I'm going to be a senior in high school in this coming year. I am, as of 2 weeks ago, 8 years NED, and I have a rotation plasty in my right leg. And today I'll be introducing Dr. Shervin Owowski, who has been an orthopedic oncologist at Emory Healthcare Winship Cancer Institute for 20 years. He is Division Director of Orthopedic Oncology at Emory University School of Medicine and is Director of MSK Oncology Fellowship. And he received his orthopedic oncology training at the University of Chicago. Thank you, guys.
Good morning. This morning, we thank you guys for being here so early in the morning for these talks. Have the pleasure of introducing several folks that are doing some outstanding research and giving them the chance to present their talks. First is Dr. Jayanthi Parthasarathy. She is here from Cleveland at the from the Nationwide Children's Hospital. She's going to be talking to us about 3D biomodeling and 3D printing to look at patient-specific solutions for complex surgical challenges in our adult and pediatric populations, and she's been doing this for over two decades. She has a in-depth knowledge and experience in navigating FDA approvals as well for medical devices. Our second speaker is Dr. Kenny Rankin from North of England, Bone and Soft Tissue Tumor Service. He graduated from the University of Dundee, did basic surgical training in Newcastle upon Tyne, followed by an MD investigating cellular biology of bone metastases. Dr. Rankin completed his higher specialist training in Perth and Dundee, Scotland, and then returned back to Northeast of England as the NIHR academic clinical lecturer. We have Dr. Matt Hawkins, also from Emory and Children's Healthcare of Atlanta. Dr. Hawkins is an interventional radiologist and an associate professor at Emory School of Medicine in the Department of Radiology. He's also the medical director of pediatric interventional radiology and specializes in treatment of vascular malformations, pediatric oncologic conditions that are amenable to minimally invasive procedures, and venous thromboembolic disease. He serves as the medical director of the Vascular Anomalies Clinic at Children's Healthcare of Atlanta, and I know he's taken care of a few of my patients, so I am very grateful for that. We have Dr. Joanne Tuohy from the Virginia Tech Animal Cancer Care and Research Center. She's a veterinary surgical oncologist and an immunologist. Her overall goal in research is to improve cancer outcomes for veterinary and human patients via tumor ablation and immunotherapy, especially with patients with osteosarcoma and lung tumors. And specifically, her research investigates the use of two non-thermal tumor ablation techniques, histotripsy and H-fire, which is high-frequency irreversible electroporation. Annie Gill is a physician. She's a radiologist and an associate professor at Emory University School of Medicine and also Children's Healthcare of Atlanta in the Department of Radiology. She works with Dr. Hawkins at CHOA in radiology and imaging services. She specializes in the treatment of pediatric soft tissue tumors, hepatobiliary disease, venous thromboembolic disease, and vascular malformations, and is also taking care of some patients in common with me. So again, very appreciative. And last but certainly not least is Dr. Jenna Kosis. She's from Cleveland Clinic, is a radiation oncology resident at Cleveland Clinic. She's from Bethlehem, Pennsylvania, went to med school at Drexel in Philly, and is mentored by Dr. Aaron Murphy from Cleveland Clinic, who specializes in pediatric radiation oncology. And their passion is SBRT for younger patients and have several projects evaluating the role of SBRT for patients with metastatic sarcoma. So without further ado, I will pass it on to Dr. Parthasarathy, who will give us our first talk this morning.
Good morning, and very good thank you to Christina and the MIB agents for having given me an opportunity to be at this very concentrated conference on osteosarcoma. I have nothing to disclose. And a little suggestion about how I'm here today. I started off as a dental surgeon several years ago, and about 25 years ago when I first saw 3D printing, it was really very intriguing. Then I said, I need to get into it because I had problems with the correction of mandibular resections for my patients, and I moved on to 3D printing, and that's how I'm here at Nationwide Children's Hospital after my surgeon and 3D printing in biomedical applications, both my master's and PhD. When we look at osteosarcoma, we have several stakeholders. We have the physicians, the patients, the families, the care team, and not to leave out the research team. When you look at patients, they are in pain, they have swelling, they have difficulty in using their limbs, and they are anxious because of the first diagnosis. The family is again very concerned, and they're all very, it was a very homogeneous family, and they were having fun, and suddenly something happened, and they are like, what did really happen? What went wrong? How am I going to set this right? When is a miracle going to happen that we're going to be back on track? So when you look at physicians, again, we have different type of physician. We have the medical oncologist, we have the radiologist, we have the orthopedic surgeon, we have the radiation oncologist, we have the pathologist, and a whole team of the research folks. Then we look at the care team, we have the nursing team, we have the radiology techs, we have the therapists, we have social workers. You name them, everybody is involved in it. And the common goal for everyone is the patient's wellness. We want to predict what would be happening, and we want to personalize the treatment and make sure that what we are planning is very optimized for the individual. And we want a participatory program where we have both the family and the physicians and the care team to completely take part in what we are deciding. And we also want to look at prevention. When we look at the physicians, the radiologists and the surgeons, both are physicians, but each one is trained in a completely different way. The radiologist is used to telling the story from the image data sets, and he's really trained to look at 2D images and construe in his mind into a volume. But the surgeon is more a physical person. He is a hands-on person, and when he opens the patient, he is going to see the volume. So it's very difficult for him to construe from the 2D images to see what he's going to see when he's opening. And on-the-fly decisions are not infrequent in the OR, but they lead to lesser optimized results. The better preparation, the better the surgery, and better the outcome. The surgeon needs to do his surgery within the least time, and he would like to have a virtual model or a physical model which he can hold in his hands. He can move, rotate, the virtual model, he can make it big or small, and he can switch on and off layers and see more concentratedly. He can also understand the spatial anatomy and the line between the demarcation between the normal and the pathological tissues. And when he makes a plan, he needs a way to transfer whatever he's planning in his mind into the operatory. And he needs to create templates for the surgery. And we are also in the age where, though we do have off-the-shelf product, patient-specific implants are becoming more and more a doable thing these days, is with the advancement of technology and imaging. A surgeon's armamentarium is first he sees the patient, he looks at the images, and then he plans in his mind, and he goes into execution. Bottom line, with all this what we said, stakes are high. We have the human life, and expectations are high both from the patient and the surgeon for the radiologist and the total outcome in turn. Post-operative corrective procedures are not an option because changing track is really, the cost is high, the healing is delayed, and productivity of the person and the morale is also becomes low. So what do we look at? There is a lot of imaging that's being taken for osteosarcoma. We have the CT scans, we have the MRI, we have the PET CTs, and for the nuclear medicine. Can we use this in a better way? An extended way. I won't even say a better way, because the diagnostics happens from the imaging, but the extended visualization happens from what we as 3D biomodeling folks do. Here we will see how we transform a CT and an MR into a 3D model, which in the virtual world you can move, rotate, and see. And you can also see a 3D printed model. We have the 3D printing these days has become a point of care facility, which makes the surgeon have the model within a few days or even the next day as needed. So this gives them the opportunity to discuss with the patients what they can do, and even as a team, what needs to be done. So here we see a scapular tumor, which is being discussed by. Advantages of patient-specific process is going to be good comprehension of the structural details and the spatial anatomy. And then the surgeon has a tactile model because he's a hands-on person, so he likes to have something in his hand. And now we see the process is really, we start with CTs, MRs, and then we create a design, and then it's printed. The guides are made out of biomedical material, biocompatible material, which can be autoclaved and sterilized. Here we do a surgical planning, and then using the guides, we see a fibula reconstruction of a humerus. And then these are some of the tools what we use with. This is the post-operative outcome, what we can see. And then this is where we co-register the CTs and the MR. Here there's a lot of coordination that needs to be right from the ordering of the imaging to the scheduling of the patients and the image protocols. And the radiologists are the best who decide the best protocol for the patient for us to make these wonderful 3D models. Here we see a pelvic tumor and we see surgical plan, how it's transformed. We also see how we do our validation process. We scan the model back into a 3D model, and then we overlay the patient's model on the printed model, and then we verify it. We published a paper recently on this. There's a pelvic tumor, there's a tibial tumor. Here the surgeon wanted to salvage the posterior portion of the fibula, and we were able to do that with a good planning. This is a distal femur tumor. I'm going pretty fast because I think my time is getting over, but we'll be able to see, most of them are pictures. So I think now we see how we can work on custom design implants with the process, with patient-specific processes. It gives you the whole inventory. So when you go into the OR, it's like you have the guides, you have all the armamentarium that you need precisely, like 1, 2, 3, 4, and it saves a lot of time in the OR. Some of the orthopedic applications, and the benefits of this are going to be good comprehension of the structural details and tactile physical model, life-size replica models, which they can give them a perspective of the complete full anatomy, and you get very precisely fitting implants, reduce operating time, lesser chances for infection, faster recovery and better patient compliance, and patients are also able to give informed consent when they have this model. Point of care manufacturing is one of the things which is becoming more and more popular these days, and many hospitals are investing in this, having known the benefits of this. For all this, you need a good quality system from start to finish. And in conclusion, we can provide better care and see the better outcomes from our patients. And my acknowledgement to my orthopedic surgeon who gave us the opportunity to do a lot of work with him, and we continue to do with that. My radiologist, especially Dr. Rees, who's in charge of the musculoskeletal, who does all the protocol and comes and validates our segmentation. And we have our advanced imaging lab, which is PAIR, and our patients who were able to work along with us and give us the opportunity. Thank you from the radiology department of Nationwide Children's. I'm not sure I think the questions will be at the end, or the questions will be at that. So if there's anything, we'll meet you again. Thanks once again.
Yes, thanks again for being invited to this meeting. I've been having a really good time, particularly discussing lots of things last night after dinner. I'm going to present to you today the sarcocyte trial, which is due to start recruiting in the UK shortly. And this is a randomized controlled trial of fluorescence-guided surgery for sarcoma versus standard of care. By way of disclosure, I have received remuneration for delivering lectures at Stryker conferences. Just to give you an idea of the setup in the UK in terms of bone and soft tissue sarcoma surgical centres, there's 5 in England, 3 in Scotland, and then in Ireland there's Belfast in Northern Ireland and Dublin in the Republic of Ireland. In the north of England, we're based at Newcastle upon Tyne, serving a population of 3 to 4 million. So essentially, from the surgical point of view, it's all about margins. You want to get a clear margin for each of your patients. And in the context of osteosarcoma, the question is, if you're going to be getting close, how safe can you be in terms of the margin? And it comes down to the millimeters. So our colleagues in Birmingham did a classification a few years ago. They had over 300 patients in the series, and with their pathologists, they were looking at the margins, and the question was, is 1 safe or 2 millimeters safe? And what they showed basically in terms of local recurrence-free survival is that if you have a margin of more than 2 millimeters and a good response to chemotherapy, then actually very low risk of local recurrence. If you have a margin of 2 millimeters or less, there are more patients getting local recurrence. And then it makes sense, of course, then that if your chemotherapy response is disappointing and the margin is 2 millimeters or less, these patients have higher rates of local recurrence. In terms of overall survival, this was really dictated, as we know, by the chemotherapy response and not so much the margins. So in summary, a response of less than 90% we know is not good. And if your margin is 2 millimeters or less, that's worse, actually. But of course, as a surgeon, you don't know what the chemo response is, and therefore the stakes are really quite high. So the goal is to get at least 2 millimeters. We obviously plan our surgery in detail. We've heard about 3D printed models and, of course, our scans. But when we're operating, there's not been many options for us to help us during the operation itself. So a few years ago, we started using this fluorescent dye called indocyanine green that fluoresces in the infrared range. And there's cameras that have become available that are really user-friendly that we can utilize in these big open operations. So the concept here is we inject the dye intravenously the day before surgery, and it will actually linger in the tumor. So the first case we did in 2019 was not an osteosarcoma, it was a chondrosarcoma, a massive tumor in the pelvis. Just as a warning in this talk, there are some images from the operating room and some tumor specimens, so apologies, it may be a little bit gory. But the next slide does show, once we'd completed the resection, I'm pointing the camera at the tumor, and we've teased the muscles apart, and you can see obviously the tumor was fluorescing. So that was impressive, and we started doing more cases, and everyone's impressed in the operating room because you're making tumors glow. But the question is it going to help? And so we set about setting up a randomized trial in conjunction with our research design service and a cancer trials team that has funding from the Sir Bobby Robson Foundation. He was a quite a famous soccer manager from Newcastle who passed away from melanoma and left funding for cancer trials. And so we spent a long time putting the application together. It did get funded from the NIHR, which is, I think, equivalent to the NIH here in the States. And we're looking to open up to 21 surgical centers in the UK. There's more centers doing soft tissue sarcoma than bone and soft tissue. We did a lot of work with our patient group, led by Roger Wilson, who's a sarcoma survivor and founder of one of our main charities in the UK, Sarcoma UK, and Ben Hood is a nurse consultant who facilitated the sessions. So we had a diverse range of participants, sarcoma patients who'd experienced limb salvage versus amputation. They could discuss the functional impact of surgery. Some of them had received fluorescence-guided surgery in our center, and some patients had experienced recurrence and metastasis. And they helped us decide whether we were going to randomize or not, and helped us agree on the primary and secondary outcome measures, and then build the application, comments on the plain English summary. And of course, they're still working with us to set up the trial and then deliver it. In terms of powering it, it's powered to see if we can reduce the unexpected positive margin rate from our historic series of high-grade sarcomas of 13.8% down to 5%. And then we have secondary outcomes, of course, local recurrence rates and functional outcome measures. But what's really neat about it is that we could then kick on and do some pathology studies, and we've built in a sub-study into the trial. So, for example, here, a sarcoma, I've taken a piece of tumor versus a piece of muscle from the same specimen embedded in the paraffin block. You take the blocks back to the operating room, and you can see the ICG is detectable in the paraffin block. If you make a 3 micrometer section, you can detect the ICG on a biomolecular imager. Apologies again for these specimens, but it really shows quite clearly here. We had an elderly patient with a high-grade osteosarcoma. He presented, he wasn't so fit for chemo, so we went straight to surgery, and you can see where I've annotated with the arrow that 1.4 millimeter margin was obviously less than 2, so not ideal. It was close to the vessels, and the fluorescence did help a fair bit in this case. But again, in terms of doing pathological sub-studies, we were able to call for this margin block, and so we can do the H&E, and I've got the margins annotated there. We've got our sarcoma marker, MT1-MMP, works really well for picking out sarcoma cells, and I was showing that marker yesterday. And then we've got the biomolecular imager, but Olympus then also have a VS200 fluorescence microscopy slide scanner, and so we could get some really good images. So the technicians put DAPI on to stain the nucleus, but then we were picking up the ICG in the sarcoma cells at quite a high power view. It took many hours to scan the slide to get these sorts of images, and then we can correlate with the H&E and the immunohistochemistry. But this has then gone on to a collaboration with Harvard. The team in Harvard have a fluorescence lifetime camera. The difference with this camera is that it pulses in nanoseconds, so that it gives you a lifetime output of the ICG. And that's really important because if you zoom in, the continuous wave is analogous to the cameras we already use. So they just have a continuous infrared beam, excitation beam. And so if you see these two areas that are bright white signal, you can't tell what is what. So on the left, those are the tumor cells. On the right, that's hemorrhage. But on the lifetime map, the tumor cells are coming up red, so high lifetimes versus the hemorrhage low lifetimes. And that's because the ICG, when it gets into a tumor cell, ends up in the lysosome. It has a different configuration, and therefore, partly due to the pH and viscosity, has a higher lifetime. So really exciting in terms of the advancements of the cameras. These are not available for our operating room yet, but we're hoping they're coming soon. Just to finish off with another case, this is a patient who had a proximal tibial osteosarcoma, and that's the soft tissue component I'm worried about next to the calf muscles. And following the resection, that's the area I've put the camera in this sort of color segmented mode, and that area is fluorescing and quite worrying. And the chemo response was disappointing, and those soft tissue components were particularly viable down the microscope. What could you do about it? We're thinking about photodynamic therapy. ICG is a photosensitizer, so it may be possible to try and treat the wound bed when you see this situation. So that's for future trials. So we're really quite excited at osteosarcoma patients in the UK. We're hoping possibly even by the end of the year, we'll be enrolled into the ICONIC study I presented yesterday, and also into this sarcocyte trial, and we can co-enroll these patients, so they've got 2 studies to go into. So acknowledgements to our patients. This is a hero of mine, Matt Haddon, on the left with Mo Farah. He had an above-knee amputation for his osteosarcoma, and he went on and did a half marathon on it. Mo Farah did it in an hour. He did it in about 5 hours, but I think he's certainly my hero, more than Mo Farah, definitely. And he did pass away a few months after that, actually. And I'd like to thank, there's lots of people to thank. There's academic trainees who had a lot of input, and they're the future in terms of bringing them forward into sarcoma. And there's so many people that have been involved in designing the trial. I have good support from colleagues at home who protect my research time to do this. There's lots and lots of people. It was just to give you a flavor of how many people get involved to get one of these trials funded and off the ground. And Harvard collaborators as well. Thank you.
Well, good morning, everybody. My name is Matt Hawkins. I'm an interventional radiologist here in Atlanta, working primarily at Children's and Emory. I do have to say it is, number one, very impressive to the meeting planning committee. This has been very well run. Content has been excellent, so very professional, so congratulations. Also, I'll speak for Dr. Gill and myself. As an interventional radiologist, we're often involved with the care of these patients, but usually it's in a supportive role, biopsies, port placement, things of that nature. So to actually get to come and speak to you all about being involved with actual therapy, again, really a privilege, and we're excited to hopefully showcase some things that could, lend itself to be helpful moving forward. These are my disclosures. So we're going to walk through, it's an interesting topic, intra-arterial therapy for osteosarcoma, and you're going to see it's going to be a lot of history of how we got to this point, and then what we can do potentially moving forward. So we'll walk through current state, some places where we're actually using intra-arterial therapy for different types of pediatric cancers. We're going to go through some of the literature that got us to this point in 2023, and then I'm going to really try and hammer home some new things, some new features of intra-arterial drug delivery mechanisms, and then talk about some next steps, specifically from an IR standpoint. So when we look, what are we doing currently with intra-arterial therapy? Because it is being used for different types of cancers. And the biggest example is in liver cancer. In fact, now in liver cancer for hepatocellular carcinoma, intra-arterial therapy has become primary therapy and gold standard as primary treatment. This is just an example of an angiogram with embolization in the middle, and then you can see the pathologic specimen, and the purple is the necrosis and the fibrotic capsule around the tumor itself. It's also, intra-arterial therapy is also being used for retinoblastoma. So children with retinoblastoma, now we can access the ophthalmic artery and use intra-arterial melphalan. And again, this has become mainstay therapy for certain stages of retinoblastoma. So I just say this so that the crowd knows This is being used in different places. We're discovering new ways to use intraarterial therapy every day. But what about osteosarcoma? So this is, Dr. Jaffe was a big proponent for intraarterial therapy, and this goes back 40 years. So we've actually been talking about intraarterial therapy and osteosarcoma for as long as 40 years. And the concept was, by infusing cisplatin intraarterially, you could achieve a higher degree of necrosis within the tumor in that neoadjuvant time period. Higher degree of necrosis would improve outcomes. And that was the original drive towards pursuing this. Now, interestingly, back in 1983, we had decent intraarterial catheters and equipment, but still pretty big. And folks would access the primary artery feeding the tumor, and then they would do a long-term infusion over the course of hours of this cisplatin therapy. Over time, people started to use cisplatin infusions, intraarterial cisplatin infusions, and follow that with embolization. So they'd use particles or some device to not just give medication, but then also block the blood supply behind that, again, achieving the goal of achieving a high degree of local tumor necrosis. And this is a paper from 2009. It's one of the last remnant papers of when this was still being done, because while it did achieve a higher degree of necrosis, we're going to talk about some randomized control studies that showed that it did not improve overall survival or event-free survival. Then this paper came out from Dr. Wilkins, and what they did, rather than just doing intraarterial therapy, they did intraarterial therapy preoperatively until they achieved 90%, what was called 90% necrosis or devascularization of the tumor, often 3 to 4 treatments prior to surgical resection. And they reported these really amazing overall survival and event-free survival rates. So people got excited about this. Of course, then we had 2 randomized control studies of intraarterial cisplatin versus intravenous cisplatin. This one from the Italian group that showed no difference in overall survival or event-free survival, and then this one as well from cancer that also showed no difference in overall survival and event-free survival for intraarterial versus intravenous cisplatin. And so largely at this point in time, it kind of fell out of favor. It really did fall out of favor. Okay. But things have changed in the last 20 years, and I think there's opportunity to at least keep this in the back of our mind as a way to, whether it's to improve limb salvage or whether it's to just improve the degree of tumor necrosis. I think we have some things to talk about. So let's talk about particles. Back in 1983, 1993, 2000, we did not have intraarterial particles to use for embolization. Now we have particles as small as 40 microns, so down to the 40 micron size. So you start talking about being able to penetrate into capillary beds, deep into tumors. These are some pathologic specimens, again, from particle embolization. These particles now, we also can coat them with iodine. And so following embolization, what you see on the right-hand side of the screen, we can actually quantify the volume of tumor coverage from the embolization. So it's no longer just me telling you that it's 90% devascularized or 70% devascularized. We can actually quantify this now in ways that weren't possible. Also, over the last 20 years or so, we're now able to put medication on these beads. So you're not just infusing medication intraarterially, hoping that some of it gets picked up by the tumor as before it exits through the veins. You actually can put a chemotherapy on these drugs, again, inject them into the capillary beds and slowly elute these drugs over time in combination with an embolic effect. This is one particular bead. Again, I don't have any invested interest in Hepasphere, but as you can see on the text in the box, one of the drugs that we are able to load onto these beads now is cisplatin and can be used potentially in a number of different ways. You can see the angiogram on the right-hand side of the screen. The pre-embolization and then post-embolization is an example of a way to devascularize the tumor, improve necrosis, and then hopefully, again, long-term improve outcomes. So what are the next steps for us? Number one, I think we have to decide what outcome measures can we help with from an intraarterial chemotherapy standpoint. overall survival and event-free survival are clearly number one, but is there a way to give more cisplatin directly to the tumor and decrease systemic cisplatin toxicity? I think that's a question for us to think about. We know from our drug-eluting bead therapy in liver tumor that the systemic dose of that tumor, of that chemotherapeutic agent, is minimal to non-detectable. So is there a way for us to deliver chemotherapy and, again, decrease some of the systemic cisplatin toxicity? Number two, if we ever pursue anything, we have to standardize our intra-arterial protocol and technique. If you look back historically, again, you had some practices where there was chemo infusion over many hours. There were some places where there was chemo infusion followed by beads, different types of beads, different doses of drugs, and so we have to standardize that before we ever pursue this. Also, we have to talk about, do we want to quantify tumor coverage, or is it percent necrosis or percent devascularization? You know, at what point have we done enough prior to surgery? And then what drugs and what dose? We can load doxorubicin on beads. We can load cisplatin on beads. There's a number of different avenues that can be taken. And then I'll close with this. IR is always, it's an exciting field. We're discovering new ways to treat all kinds of different diseases, but I do think it's really important for IR practices to be very involved with their oncology teams and their solid tumor teams. We need to hold ourselves accountable, make sure we're present all the time so that you all know about what things are coming down the road in different types of cancers. And then lastly, I'll close with, if we ever do pursue this, we have to make sure that it's not just any interventional radiologist that's treating this. We have to have a small group of us that can develop expertise, so that our kids can make sure they're getting the best therapy possible. And with that, I thank you very much for your time.
Good morning, everyone. I'm so honored to be here at the Factor Conference. It's my first conference, and it's been an incredible experience. And thank you for the opportunity for me to talk to you a little bit about our team's research into advancing tumor ablation techniques for treating osteosarcoma. And I have no disclosures. I am a veterinary surgical oncologist and an immunologist at Virginia Tech, and I work with a wonderful team of people to try to advance tumor ablation for osteosarcoma treatment. And our work is firmly grounded in the One Health principle, where we hope that the work that we do to advance treatment for osteosarcoma in dogs will also eventually help people with osteosarcoma. And I don't need to emphasize to you, after the wonderful panels yesterday, about the strength of the pet dog as a comparative oncology model. And so all I wish to show you is a picture to demonstrate one of the strengths of the pet dog, which is that pet dogs share our environment and stressors, environmental stressors and exposures. So here is my dog and my husband sharing the same environment, taking their afternoon nap. And so, indeed, they do share a lot of things, including treats. So the challenges with osteosarcoma treatment, again, I don't need to go into detail. I know that all of us are very well aware, and some of us all too intimately, about challenges with treatment of the primary tumor, for example. Currently, we primarily depend on surgery to resect the primary tumor, and surgery is invasive, and often with limb salvage surgeries for dogs and people, multiple surgeries can be required. And so a method to help patients avoid or reduce the number of surgeries for the appropriate patient, in my mind, is a worthy cause. And so the other challenge that we face is treatment of metastatic disease. Metastatic disease is a huge hurdle in improving survival in osteosarcoma. And so in my opinion, the optimal treatment modality in this whole multimodal treatment approach to osteosarcoma and other cancers is the ability to treat primary as well as address metastatic disease. And this is where I see histotripsy the novel ablation technique about which I'll speak with you this morning, it's where I see it fitting into the multimodal therapy approach. So histotripsy is unique as a tumor ablation technique. It is non-thermal and non-ionizing, and it's non-invasive. And so for eliminating the primary tumor, I think it has great potential to offer a non-surgical limb salvage option. And also with preclinical studies especially, it's been shown that after histotripsy ablation, there is immune modulation such that there is decreased metastasis as well as increased synergism with adjunctive therapies. And so some of you may be wondering, what on earth is histotripsy? Well, if we take the word back to its Greek roots and break it down, so histo meaning tissue and tripsy meaning breakdown, we literally get mechanical disintegration of this tissue in the focus of histotripsy treatment. So it is a focused ultrasound technique that utilizes acoustic cavitation to achieve mechanical destruction of tissue. And this cavitation refers to these micron-sized bubbles that form in the tissue at the point of the focused ultrasound ablation. And that point is determined by the operator, so by us. And when these bubbles coalesce, they increase in size, they individually increase, decrease in size, and therefore exerting stress and strain on the surrounding tissue. And at a certain threshold, we have cavitation collapse. And so when this bubble collapses, then, or this bubble cloud collapses, then that pressure exerted on the surrounding tissue also causes mechanical tissue disintegration. And so on the right here, you see this custom histotripsy transducer with 32 elements that was designed by one of my bioengineering colleagues. And then in this image, you'll see the cavitation cloud that is a hyperechoic region on ultrasound imaging that we can view in real time during histotripsy ablation. And so with this promise of histotripsy as an ablation technique for osteosarcoma, we wanted to investigate its ability to treat osteosarcoma in dogs. And so we did some ex vivo studies, initially just removing pieces of osteosarcoma tissue after limb amputation in dogs and establishing our histotripsy ablation dose that's effective for eliminating the tumor cells, and also established that at those doses, there was no histologic change exerted on normal bone and normal nerve. And so those results, ex vivo results, then enabled us to open canine clinical trials, a series of them, where these are treat and resect studies. So dogs receive histotripsy to a portion of their tumor and then underwent amputation and chemotherapy after. And so we've assessed the histotripsy efficacy. So we showed that histotripsy is very effective at destroying or ablating these tumor cells. And then currently we're carrying out our evaluations of the tumor microenvironment, the immune cells in the tumor microenvironment, as well as the peripheral blood. And those evaluations are ongoing. So this is a histotripsy system. I just wanted to show you. We've got our canine patient here under anesthesia, and this is the whole histotripsy cart that is used to deliver the histotripsy treatment. And then on the right, you'll see the histotripsy delivery parameters for anyone who may be interested. And so this is a little video that I wanted to show you of the cavitation cloud that, of the cavitation cloud that forms. And I'm not sure if the video is going to play, so apologies for that. But it shows up as a hyperechoic region on the on real-time ultrasound. And so with those exciting results with the efficacy of these dogs, osteosarcoma dogs that underwent an amputation after histotripsy, we've now opened a clinical trial for dogs where we treat with histotripsy the entire tumor, and then we're not amputating. So it's a treat and leave study. But as we advance towards those studies, we need a way to monitor these ablation zones over time, identify and monitor them. So initially we tried CT, and as you can see with the CT images of various tumors on the left compared to post-treatment images on the right, really no difference between them. And so we turned to MRI, and MRI indeed has shown to be quite effective at identifying these ablation zones. So we've got the untreated tumor here, and then in the red circle we have a hypointense area on MRI that shows up. And then this is just another example in another patient where we have a pre-treatment tumor and then a post-treatment tumor on MRI. And so having these results, we can see a region on the MRI, but what does that mean? So correlating to gross examination of the tumor after ablation by our pathologist, she measured out an area that is determined to be the gross ablation zone, and this measurement is carried out by predetermined anatomic landmarks and matched to the MRI measurements as well. And so, as you can see in these two examples, the MRI and the gross tumor measurements match up quite well. And I'm sorry, the numbers may not show up very well, but they're within millimeters apart. And this is just a little chart to show you the 8 patients that we had preliminarily where we had this pilot study to determine the efficacy of MRI. And you see that these little dots here represent each of the patients, and the dots represent the difference between gross and MRI measurements. And as you can see, they're within millimeters of each other, as these are 1 centimeter marks. And so we've got a little outlier here, but overall we're very pleased with these results. And histologically, what do we see? We again confirm that we have ablation that's successful, so untreated tumor with tumor cells, and then a sea of pink necrosis in the treatment zone. And so these treatment areas histopathologically also measure up and match well with what's measured on MRI. And so we do a lot of work in our laboratory to synergistically combine preclinical techniques, so using murine models, tissue models, cell culture models, to combine with our clinical canine data to help advance histotripsy towards clinical translation for our canine patients and hopefully for human patients as well. And so just to highlight some of the work that we do, we have a lot of work ahead of us, but we're very excited about it. We are evaluating the strength of bone after histotripsy ablation and also our ability to predict fracture, because that is a very real risk after tumor ablation of bone tumors. And investigating some bone support and replacement techniques as well, and improving our ability to visualize and also determine the histotripsy ablation while it's happening in real time. And so this is my lab, and the work couldn't happen without them. We're all a team, and also my very generous funders, without whom this work would not be possible. Thank you.
Good morning. Can you advance to the next slide, please? Oh, I do it. Just kidding. There you go. I'm Dr. Gill. I work with Dr. Hawkins at Children's Healthcare of Atlanta, and I am also a pediatric interventional radiologist, and I get the distinct pleasure to talk to you this morning about ablation, percutaneous ablation. And without further ado, here we go. These are going to be our objectives this morning. And I wasn't entirely sure how many of us are familiar with ablation, so that's where we're going to start. These are 3 different thermal ablation techniques, so you've heard a little bit people talking around this topic. But this technique has been available for several decades. And really the first ablation technique or modality that we had was radiofrequency ablation. And you can see here, I did some cute little icons there to sort of give you a hint as to what it uses. So it uses radiofrequency energy to kill and burn tissue. And so there's the largest amount of data that's available with this technique. But quite honestly, there are several other modalities that are now available that provide not better ability to kill tissue, but maybe more elegant design of how you do it. So one of the next modalities that we use is microwave ablation. And this uses microwave energy to burn and thereby kill tissue. And modifications were made with this device based on the radiofrequency ablation data that we had, which allowed larger and more confluent ablation zones, and that was using probe synchrony. And then you also have some not so great things, because you can lose part of your ablation zone with something called the heat sink effect. So, Dr. Hawkins talked about the liver. Microwave ablation in the liver, you have to be careful how close you are to blood vessels, because as those blood vessels have blood that's passing through it, it will cool your ablation zone, all right? And so you're not able to get as large a zone as you want. But it is great. It has short procedure times. There's quite a lot of data out there about using it in bony and soft tissue tumors. And then lastly, this is where we're going to focus most of my talk on, because we are going to focus on talking about ablation in the musculoskeletal system for the most part, and that's cryoablation. So it uses a effect called the Joule-Thomson effect to exchange gases down a probe. And when that gas exchange happens, it freezes the tissue at the end of the probe, and then the probe comes out of the tissue, so you're not left with a probe inside your body. But you are able to do similarly what you can with microwave, in that you can combine several probes to create very large ablation zones, or very large areas of frozen tissue. But you can still experience some heat sink effect with the freezing of tissue, but it's sort of the reverse. If you have blood vessels that are pumping warm blood next to your ablation zone, that will shrink your ablation zone. And then it does have longer procedure time, so it roughly takes us about 30 minutes of freezing and thawing when we're doing an ablation to complete the procedure. And so a little bit more deeper dive onto cryoablation. I use this example that's been published and well referenced as a nice slide for you to see exactly what happens. This is a kidney tumor that has an ablation probe through it. You can see the probe marked there with the star. And so you have the actual portion of the tumor that you want to cover, and that's your necrosis area. And that's the area that you really want to get to the at least negative 25 degrees or even negative 40 degrees Celsius. And then you have your ablation zone, which is going to be the warmer tissue around it, still getting frozen, but not necessarily to the necrosis area. And so that is your margin that happens. And so really, if you're looking at killing tissue, we do 2 freeze cycles, and usually a freeze cycle is anywhere from 8 to 10 minutes long to be able to achieve those extreme cold temperatures within the body. And then you'll go through a thawing phase afterwards, and usually that's about 5 minutes to allow a thaw to happen. You can either do a passive thaw, where you just simply turn off the freezing, or you can do an active thaw, which actually warms the probe, warms the tissue, and then it lyses the cellular components that are then exposed to the body, and the body's immune system is able to see those components, those tumor tissue components that are now the proteins that are released, and being like, hello, I'm here. And it can almost form an immune response then to some of those proteins that are then released and shown to the body's immune system. And then you do the same repeat. You don't move the probe, but then you freeze for your second 10 minutes and thaw for your second 5 minutes. So that equals about 30 minutes. These are the actual probes that we use. So people always ask me, well, what does the ice ball look like? Well, there you go. Those are the ice balls. And we have a variety of probe shapes and sizes that we can use. And this is one of our metrics that we use here when we're calculating how large we want our ablation zone. And these are single probes here, but then, of course, we need to make larger ablation zones, and so you can put probes together and create confluent, large, freezing probes. And so then this is an example here. If we take that concept a little further, how many probes can you put together? Well, I've used something as large as 7 probes to create a very large ice ball in a tumor. You can use as small as 2 or even a single probe, as I'll show in some of our cases that we're going to review. But it is very dependent upon imaging. We use MRI and CTs for our planning ablation zones, and then we use cone beam CT while we're in the procedure to make sure that we like exactly where we're going, if we need to add one, take one away, or those types of things. And then as far as complications, this is a thermal process, so if you are too close to the skin, you will in fact cause skin injury or actually freezing of the skin, and so you have to be careful, particularly in children, how close you're getting.
But it does provide almost immediate pain relief within 1 day or 6 months after the procedure. I would, in my experience, say it's much closer to the 1 day of having pretty profound improvement in pain. We're going to talk about some pearls and some pitfalls. I listed the pearls here because they have come about from some of our pitfalls. But we really tend to use cryoablation the most in musculoskeletal system. It's tolerated the best by the body. It has less procedural pain. Sometimes with microwave ablation, it can be such a jarring effect for the body to actually be burned that you can have some pretty bad pain after the ablation itself. Also, if you're next to a nerve, after you burn a nerve, it doesn't really come back, right? And so if you freeze a nerve, there is the potential for it to regenerate and regrow, and you know that from data based on intended cryoneurolysis, that the nerves do regenerate and regrow. We often do use neurophysiologic monitoring because we want to make sure that our nerves are being avoided if at all possible. And often we perform these procedures with nerve blocks, and we use antibiotics during the procedure to make sure that we don't have any bad infection risk. This is a patient of osteosarcoma that had a rib lesion here that was very painful, as well as a humerus lesion that was very painful. He was only controllable with IV narcotics and a PCA pump. We did a tiered ablation for him. We first treated the rib lesion and then the humeral lesion, and you can see here the cone beam CT with the 3 probes placed in the humerus lesion. And within a week of each, he was done with his treatment. He was discharged home on post-op day 1 from his humerus ablation, and he did very well. He was able to be controlled well on oral pain medications and no longer needed the IV pain medications. Unfortunately, 5 months later, he did succumb to his disease with sacral mets and sepsis. This is another patient with Ewing sarcoma that this is his PET CT showing a very painful and hypermetabolic lesion in the right distal femur that we did ablation for. Here we ended up using 4 probes to be able to completely cover the lesion and have complete necrosis with the MET. And then 4 months after, there's his follow-up PET CT showing a durable effect that the tumor was in fact killed. Palliative ablation for pain control is another big area for us using cryoablation. This is one of my patients that had a very painful rib met from rhabdomyosarcoma and just could really not get any relief. And we treated it with 3 probes across the rib lesion. I will point out here that we had to be careful that we were not too close to the skin, so I placed the probes deep within the tissue there. And she no longer needed pain medication after this, was able to go home. And then finally, looking at metastatic control for lung lesions with patients that have sarcomas. This was a patient with Ewing sarcoma that had multifocal pulmonary mets, as you can see marked by the red arrows here within the ablation probes. So we treated all 3 of these lesions in a single session. And she did not want to go on chemotherapy any longer, but wanted to have local control of her pulmonary mets. And so we did multifocal treatments and multiple treatments. She did have a complication from this. She had a large pneumothorax that required a surgical pleurodesis to eventually fix it. But it was fixable, and eventually she succumbed to her disease, but we controlled her pulmonary metastatic disease for a couple of years with this technique. And finally, this is another patient with a single pulmonary met, but we flanked it with 2 cryoablation probes, one on the top, one on the bottom, as you can see from that middle video image. And there's the post-ablation image on the far right. And then this is what it looks like. So when you're looking at it, it's really important for your radiologist to know exactly what they're looking for, because 1 month post-ablation, it almost looks like the met grew, but it didn't. And you can see 4 months later, it has more linear appearance with a central cavitation, and then finally, 18 months after ablation, it's just a linear scar within the lung without any recurrent metastatic disease. So in conclusion, we feel that ablation can be used in a wide variety of soft tissue and bony tumors, and repeat ablations can be necessary. Successful ablation zones do require meticulous planning and correlation. Close follow-up with labs, clinic appointments, and ablation imaging is necessary, also making sure that your radiologist knows exactly what they're looking for so they don't call an ablation zone a recurrent area of disease. And then it can be a durable method for local control of soft tissue and bony metastatic disease. All right, thank you.
Hi, everyone. My name is Jenna. I'm a radiation oncology resident at Cleveland Clinic. I'm very grateful to be here today to discuss with you our experience with SBRT for patients with metastatic osteosarcoma. And I wanted to thank Victoria's family for helping fund me to be here today. I have no disclosures. So what is SBRT? Stereotactic body radiotherapy. It's a method of external beam radiation that's able to accurately deliver a high dose of radiation in a limited amount of time and a few doses to an extracranial target. It requires the target to be accurately localized using site-specific imaging, as well as being able to delineate the organs nearby at risk, make sure that there's a little bit of separation between the target and those critical organs. It's performed with a machine called the linear accelerator, and that machine itself is equipped with image guidance, so we can see the tumor and the organs at risk as we're delivering the treatment. We have highly conformal delivery methods such as IMRT and VMAT. And then every day prior to treatment, we do have that updated image where we're verifying alignment prior to giving the treatment. The benefits for SBRT in the adolescent and young adult population include this short amount of time, these 1 to 5 day procedures, rather than the traditional radiation courses that can take 4 to 6 weeks of therapy. It can reduce anesthesia needs for younger patients who might not be able to stay still for longer periods of time, so we have the short procedure. Less impact on daily routines and education, and a very quick recovery, meaning that these patients might not even have any side effects, and then they can keep going to school and doing their daily activities. SBRT uses multiple intersecting beams, so we're able to focus this high dose on this very discrete volume. It spares normal tissues as it has a high dose fall off right around the target. And by that technique and by being able to focus all those beams on that location, we can increase this biologic effectiveness dose. We can increase the dose as we know we can spare the normal tissues right around it. So we use SBRT for these patients in unresectable disease, localized recurrent disease, oligometastatic disease, so a few sites of metastases, and consolidation of metastases. SBRT is heavily used in the adult population, so we have the availability is there, and we have a lot of experience in adults. So there is limited SBRT data in the adult and young adolescent population, and specifically in osteosarcomas, which are known to be radio-resistant. So that's why a lot of osteosarcoma patients don't meet a radiation oncologist up front, because they're known to be resistant to radiation. So with SBRT, this technique where we know we can increase the dose as we have the technique to avoid the normal tissues around it. So by increasing the dose, we believe we can increase the local control in sarcoma patients. Patients with limited metastases in lung and bone are considered curable if we have this aggressive local treatment. This is some data from a registry of osteosarcoma and sarcoma patients with lung metastases who undergo surgery to remove the metastases. And they do have a 5-year overall survival around 30% if they can surgically remove them. We have the Ewing sarcoma study where they looked at patients with metastatic disease outside of the lung, and there was data showing that if we locally treat the primary site as well as all the metastatic sites, the 3-year event-free survival more than doubles when we treat both sites. So we believe that SBRT could have a significant outcome on sarcoma patients with unresectable metastatic disease. So we have a paper soon to be published this year looking at our experience of using SBRT for metastatic and recurrent sarcoma patients. We have 42 patients where we treated about 138 lesions over the past few years. This whole database includes radiosensitive and radioresistant sarcoma patients, including osteosarcoma. The average age of the patient treated was around 21 years. And you can see in the bottom right there the location of the metastases. So around 75% were in the bone, but we do treat other soft tissue areas, lung and liver lesions as well. Our median follow-up in this database is around 10 months of imaging data so we can track or control. The median time from development of recurrent metastatic disease to SBRT was around 14 months. So a lot of these patients, when they'd have a recurrence or new metastases, they're getting treated with other therapies first, chemotherapy, other systemic agents before they get to us for radiation. When we started this, kind of figuring out what the optimal dose is, as you can see on the right, there was a lot of different regimens that were used, but the median dose was 30 gray and 4 fractions. In this database, for all sarcoma patients, we had a 1-year local control, around 67%, kind of equivalent there when we separated into radiosensitive and radioresistant. But by using an ROC curve, we were able to determine a significant dose cutoff where we saw better outcomes. So a BED is kind of a calculation where you look at the total dose, the dose delivered per fraction, and the number of fractions, and you can kind of make an equivalent dosing number there. So by looking at this dose of greater than or equal to 95 gray, we saw a significant cutoff in the 1-year local control, where patients receiving that higher dose have a control around 75% at that 1 year. And it holds for radiosensitive histologies where there's that significant cutoff of control. And then the radioresistant histologies, there's a trend towards better control with that higher dose, but it was not significant. So this leads us into my current research, which is determining an optimal dose for osteosarcoma patients using SBRT. So I used the same registry from prior, but focusing only on the osteosarcoma population, looking at local control, overall survival, and toxicity. There was 23 osteosarcoma patients in the database. We treated 66 lesions total. Again, the average age was around 20 years old, with around 10 months of follow-up. In this population, the median dose delivered was 40 gray and 5 fractions, which calculates out to that BED of 120 gray. And around 70% of the lesions were in bones, and then we did have 20% lung and liver and some soft tissue metastases as well. 61 of the lesions had follow-up imaging where we were able to track local control outcomes. The 6-month local control was around 90%, and the 12-month local control was 78%. Again, we found a significant cutoff where outcomes were improved significantly. So this cutoff was found at the BED of 120 gray, where we look at patients treated with 120 gray or higher, and that was 89% 1-year local control compared to that lower dose where it's only 61%. And that 120 gray equivalates out to that 40 gray and 5 fractions. Our overall survival, 12-month overall survival rate was 65% with the median overall survival of 14 months. The good thing was there was no acute grade 3 or greater toxicity, meaning patients didn't need to be hospitalized or to undergo procedures for any side effects that they may have had. Only 4 patients had a grade 2 toxicity. The side effects were esophagitis, a pneumonitis, and then 3 patients had a pain flare, which was caused just by the inflammation from that radiation dose. All were managed at home with steroids or pain medications, and all symptoms resolved. 1 patient did have a late toxicity that required a surgical intervention for pain, which that procedure did completely resolve the pain. So in conclusion, we have a large osteosarcoma database of patients treated with SBRT. We know that SBRT offers a local control benefit with minimal toxicity for recurrent metastatic osteosarcoma patients. And here in this database, we can show that the local control is improved when we have this higher dose. We're able to use this BED of 120 gray. So with this, we recommend using SBRT for more osteosarcoma patients, utilizing them on trials. At Cleveland Clinic, we now have a sarcoma SBRT immune trial, so we're looking at how the immune system changes after SBRT. And so we're hoping that can kind of guide treatment in the future as well. I wanted to thank our radiation oncology department at Cleveland Clinic, all the nurses, therapists, dosimetrists that help us safely deliver this high dose to our adolescent and young adult population. We have a close relationship with our neurosurgery and pediatric team, which has been an awesome relationship to learn and grow from them as well. Thank you to my mentor, Dr. Erin Murphy. She's taught me so much. I'm so thankful to be here. And thanks to the Little Warrior Foundation and the Power of Will for helping to fund our current clinical trial and kind of all the expertise and data that we have on this topic. And again, thank you to MIB for having me be here.
All right, well, thank you so much for all the speakers, for the excellent talks, and for staying on time. Highly appreciated. So we'll go to the question and answer session. Primarily love to take some questions from the floor, from the audience. We have a few questions on Slido that I can run through as well, and I personally also have a couple of questions for these excellent speakers. But anyone have any questions?
First question is here to the left.
Morning, Bruce Smith from Auburn. Dr. Tui, what's the applicability of histotripsy to pulmonary metastases? I realize bone is an issue, depth is an issue, transducer array is probably an issue, but is there a potential there?
Thank you. Is this on? Oh, great. Thank you for that question. So, excellent question. Because histotripsy utilizes focused ultrasound or just in general ultrasound waves, at this time, the technology is not yet adaptable to ablating tissues with air. And so it's limited in the lung, but we're investigating other tumor ablation techniques for ablating lung lesions.
We have two questions back here at the back table, to your left.
Alex Huang from Rainbow Babies and Children's Hospital. This question is for Annie on the cryoablation question. Is there any difference intrinsically about using argon versus nitrogen for your cryoablation, number one? And number two, do you always try to achieve complete tumor ablation with cryo? Or there's some anecdotal data that shows maybe partial cryoablation results in better maybe immunological response versus complete. And have you ever seen a scopal effect that comes from that?
Thank you for your question. We use argon gas because that is what is recommended by the manufacturer for the probes. I don't know much about using the nitrogen gas because what you're really looking at is the expansile ability of the argon gas as it is channeled down that probe. But I mean, if you want to give me your contact information, I'd be happy to investigate it further with our manufacturer. Next, about lesion coverage, it is always our goal to provide complete coverage of the lesion with our ablation zone, much like was discussed in one of the other talks about making sure that you have your margins covered. That is similarly our goal with ablation, is that we really want to extend the coverage, usually about 5 millimeters, sometimes as less as 3, but usually 5 millimeters in all directions of the lesion. And then as far as the abscopal effect, I think there's more data to come on this. You know, some people have a really amazing response after the abscopal effect, after those denatured proteins are visualized by the immune system, and some people don't have a great effect. There are some trials right now that Dr. Hawkins and myself are a part of in looking at the pulmonary mets and immune regulators of doing that very thing of after cryoablation, does it improve the abscopal effect with addition or subtraction of immune modulators? So I have seen amazing things with abscopal effect. I've seen also some pretty poor response. So our goal would always be to provide local control with complete ablation coverage of the tumor.
For our last speaker, Dr. sorry if I'm butchering your last name. I was wondering how your overall outcomes and the SBRT compared to historical.
Yeah, I think on the historically we just didn't know what dose to use. So now that we can kind of increase the dose, the local control is, the patients are staying disease-free in that area for longer periods of time, and as we can see out to the 1 or 2 year mark that we have data on. I can talk to Dr. Murphy and see kind of years ago what the local control benefits were with older techniques, but I know SBRT kind of wasn't even used for this, many years ago, and so the dose just wouldn't be as high enough that would be able to offer any control. It'd be more of like a palliative intent for a shorter period of time.
See, and Dr. Tui, I wanted to ask about the exclusionary criteria in your canine trials. Are there certain bones that are not amenable to this?
Thank you for your question. Thank you for your question. So for our initial trials where we had the treat and resect trials, we were excluding patients with tumors in the proximal portions of the appendicular bone. So in the proximal humerus, for example, and in the proximal femur. Those were exclusions for our very earliest trial. And then once we established more comfort with the technique in our subsequent trial, also treat and resect, we started to include those patients as well. But there are still limitations, and there's a lot of work to do, limitations with regards to accessibility in those more proximal lesions within the appendicular bone.
Question in the back?
We have another one here, and then one more in the center, and then there are a couple in the slide out. Maybe we can address them.
Good morning. My name is Sabrina Faris. I'm a medical student from Indiana University School of Medicine. My question is for Dr. Parthasarathi. So at Indiana University, we also have 3D printing core and whatnot. And I wanted to ask you, what are some ways that we can encourage surgeons and others to be able to make use of the 3D printing facilities for surgical planning and whatnot?
So I think the question was, how do you get surgeons to use the 3D printing options that are available? Is that correct?
I mean, it's basically the relationship and how you show them what you can do. Probably the first few cases I'm there with the surgeon for most of these surgeries. So I really see how he uses the model and how we can do things better for them. Yes.
And I'll answer that as a surgeon. Anything you can do to make my life easier would be great. So it's not going to take a lot of arm twisting to have me do that. Now, we do use 3D printing quite a bit in what we do.
Yeah, just to second that, in our center, a company came in and offered a few freebies and then got us hooked. So we use them all the time. Yeah.
Next question's back center.
Hi, I'm Erin Murphy from the Cleveland Clinic. Congratulations to all the speakers up there. Great job, great work. I think we're really headed in a better direction for local control for these tumors. Dr. Rankin, you did a great job kind of sharing the data with, even with your fluorescence guidance, if you have less than 90% necrosis and less than 2 millimeter margins, we still need to do better. And I just want to put it out there, perhaps when patients have that situation, they should at least maybe consider to meet with a radiation oncologist up front. You know, our field has really continued to advance with technology and able to get in higher doses in a safer way. It certainly is worth a discussion, I think, for those cases, right, where they need something more done.
Yeah, that's a good point, because obviously we say osteosarcomas are traditionally radio-resistant, but that's when they're still, the main tumor bulk is there, the main mass. But if you think about soft tissue sarcoma, of course, we treat with radiotherapy either pre-op or post-op. And if we're giving post-op, it's about mopping up any residual cells. Right. So in theory, a few residual osteosarcoma cells may be taken out by some radiotherapy if you've got a close or unexpected positive margin. I think it is a very good point, which I think it needs to be highlighted again. Yeah, definitely.
Yeah. I envision a clinical trial one day, right, for those closer positive margins, poor necrosis rates.
Yeah, exactly. So that's so there are some interesting studies that have used brachytherapy and photodynamic therapy. The teams in Japan have done a lot of work in that area, and that's the point really. If you've got potentially some residual cells left behind, using those adjuncts to hopefully reduce local recurrence rate.
Great, thank you.
Thank you to the panel. For the sake of keeping on time, we're going to have to stop the questions. We do have a number of questions in Slido that hopefully can be addressed by the panel either directly or within the Slido tool. Thank you.